Welcome to the deep dive. You sent us a really focused source this time,
hmm
a detailed chapter all about managing foot problems in people with diabetes. It might sound specific, but wow, the implications are huge and honestly, a little stark.
They really are. I mean, just like looking at the numbers in your source material kind of tells the story.
Yeah.
Diabetes impacts what, 25.8 million Americans?
Yeah,
That's like 8.3% of the population. And we're seeing about 1.9 million new cases every single year.
that's staggering.
And it also hits minority groups harder. The risk, for instance, is 77% higher for non-Hispanic blacks compared to non-Hispanic whites.
And tragically, the source points out that foot issues, they're the most common reason someone with diabetes ends up in the hospital.
That's right. And they're the leading cause of lower leg amputations in the U.S.
Leading cause.
It's a chilling statistic, really.
Yeah.
Over 60% of lower limb amputations that aren't caused by like an accident or trauma, so roughly 65,000 a year, happen to people with diabetes.
Oh, man.
And, what's really heartbreaking is that about half of those who lose one leg, well, they face losing the other one within 5 years.
Okay, let's dive in then. Our mission here is to unpack this chapter, understand why these complications happen, why they're so devastating,
Right.
how they're identified and handled, and maybe most importantly, what you, our listener, can actually do, based purely on the insights in this text.
Sounds good.
So let's start right at the root cause. Why does diabetes specifically target the feet like this?
Well, at its core, diabetes messes with how the body handles carbohydrates.
Right.
So you get consistently high blood sugar, hyperglycemia,
Okay.
and this high sugar level, over time, it just damages blood vessels everywhere,
Mm.
both the tiny ones, the microvascular, and the bigger ones, the macrovascular.
Think of it like trying to run syrup through fine pipes, it just gums things up.
That's a pretty good analogy, yeah. It gums things up, damages the structure.
So it's not just a number on a test, it's actual physical damage from that persistent high sugar.
Exactly. And your source highlights what it calls a critical pathophysiologic triad that leads to these foot problems, especially ulcers.
Okay, a triad. What are the three things?
Ischemia, which is just poor blood flow. Neuropathy, which is nerve damage. And then an altered response to infection. Your body just doesn't fight it off as well.
Let's dig into that damage from the high sugar itself. How does it actually break things down, like at a cellular level?
Well, beyond the obvious vascular damage speeding up atherosclerosis, that rest in the pipes thing,
Right.
the high sugar triggers specific biochemical changes. For instance, something called the polyol pathway gets overactive.
Okay, polyol pathway.
Yeah, it leads to substances like sorbitol building up inside nerve tissue.
Sorbitol, what does that do?
It's kind of like a sponge. It pulls water into the nerve cells, makes them swell up.
Ah, so the cells actually get physically bigger.
Yeah, they swell.
Yeah.
And that physical change slows down the signals the nerves are trying to send. Eventually leads to permanent damage.
Right.
Your source also mentions that HbA1c, that marker for long-term blood sugar control.
Yeah, the A1C test.
Right. High levels of that actually bind onto oxygen more tightly, so less oxygen gets delivered to your tissues.
And tissues need oxygen to survive, to heal.
Precisely. And high sugar also makes protein stiffer. It's called glycosylation.
Okay.
This can stiffen joints, like in the foot, changing how you walk and creating weird pressure points. And really importantly, high sugar impairs your white blood cells.
The infection fighters.
Yep, makes it harder to fend off bacteria.
So hyperglycemia sets up this perfect storm.
Yeah.
Damaged vessels mean poor circulation, damaged nerves mean you can't feel things and your foot shape changes, and a weak immune system means infection gets in easily.
That's a great summary. It really is a perfect storm.
Let's focus on the nerve damage then, the neuropathy.
Yeah.
Your source says, 60% of people who've had diabetes for 5-10 years already have it. That's huge.
It's incredibly common. And the most relevant type for foot problems is peripheral neuropathy. It specifically hits the nerves furthest from the spine.
So out in the hands and feet.
Exactly. Often in what they call a stocking glove pattern, meaning the longest nerves, the ones going to your toes and fingers, they get affected first. It kind of creeps upwards.
And this is where that dangerous loss of feeling comes in, right?
This is absolutely the key takeaway. Peripheral neuropathy damages different nerve fibers. You've got the large fibers for light touch and proprioception.
Proprioception, like knowing where your foot is without looking.
Exactly, your sense position. Losing that makes your gait unsteady. But, crucially, it also damages the small fibers.
And they do what?
They detect pain and temperature.
Ah.
This is the really insidious part. You could step on something sharp, have a rock grinding in your shoe, develop a blister, and you just don't feel it.
So minor injuries just go completely unnoticed.
And untreated. Exactly right.
Mhm.
The source even gives that case study example, CC, right?
Mhm.
Had a wound for a month, didn't feel any pain, only noticed because of an odor.
Wow.
And add to that motor nerve damage. That weakens the small muscles in your foot.
Okay, so what happens then?
Well, it leads to structural changes. Your foot shape literally changes. You can get toes curling up. They call them hammer toes or claw toes, maybe really high arch, pescovus, or a bunion, hallux valgus.
And these changes, they cause problems.
Oh, yeah. They shift how weight is distributed. They create spots, usually under bones, with extremely high pressure. Perfect spots for the skin to break down.
And there's another kind of nerve damage too, autonomic.
Yep, autonomic neuropathy. This messes with the automatic stuff like sweating and blood vessel control.
Okay.
So pseudomotor neuropathy means the sweat glands in your feet just stop working properly.
Leading to?
Dry, cracked skin, which is basically an open door for bacteria. And then vasomotor instability can cause blood to kind of bypass the tiny capillaries right at the skin surface.
So even if blood is getting to the foot, it's not getting to the very outer layers. Less oxygen again.
Right. Lower tissue oxygen right where you need it for healing.
Okay, so we've got nerve damage, vessel damage from the sugar.
Hmm?
Let's talk more about that vessel damage, the peripheral vascular disease, PVD.
Right. So PVD in diabetes involves changes inside the vessel walls.
Yeah.
You get deposits, platelets, fats, calcium, cholesterol. It narrows the pipes.
Is it different in diabetes compared to PVD in someone without diabetes?
There are some differences. One unique thing mentioned is that it often heavily affects the smaller arteries below the knee, the tibial and peroneal arteries,
All right.
while sometimes the main artery on top of the foot, the dorsalis canis, might be relatively spared. That can be important later if someone needs, like, bypass surgery.
But the overall effect is still reduced blood flow, right?
Yeah, absolutely. The vessel walls thicken, blood cells get sticky and clump together, tiny clots can form. It all reduces flow. Tissues don't get enough oxygen, enough nutrients. They can't stay healthy, can't heal well.
And if the blockage is really bad?
Well, large vessel blockages, what they call macroangiopathy, can be so severe they lead directly to tissue death, gangrene.
And when you put together the lack of feeling from neuropathy with the poor circulation from PVD.
That's the perfect setup for diabetic foot ulcers. Your source explains these often start because of that combination, progressive loss of protective sensation and diminished blood supply.
So a small injury happens, you don't feel it,
And then the tissue can't heal properly because it's not getting enough blood.
and infection joins the party.
Almost always in established ulcers. And it's a disaster. It destroys tissue rapidly, leads to gangrene, amputation, if it's not treated aggressively. The source lists the usual suspects for bacteria, gram-positives, gram-negatives, anaerobes, and notes MRSA is becoming more common.
MRSA, yeah.
And they stress, culture the deep tissue if you suspect infection. Don't just swab the surface goo.
Okay, and what about the Charcot foot thing? That sounds really dramatic, like the foot just changes shape.
It's a really devastating complication. It happens because of severe nerve damage. The source describes it as progressive destruction of bones and joints in the foot.
How? Why does that happen?
Well, there are two main theories mentioned. One is neurotraumatic, basically, because the foot is numb.
Mm-hmm.
Repetitive minor trauma just from walking causes tiny fractures you don't feel. You keep walking on it and it just breaks down. The other idea is neurovascular, that those autonomic nerve changes mess with blood flow in a way that weakens the bone structure itself, making it super prone to collapse even with normal stresses.
And what does it end up looking like?
As the bones and joints crumble, the foot can get really deformed. A common outcome is this rocker bottom shape. The arch collapses and the middle of the foot kind of bulges downwards and outwards.
Creating a new pressure point.
Exactly. A big bony lump right on the sole where you walk. Extremely likely to develop an ulcer right there. Your source also notes that when it's acute, first happening, a Charcot foot can be swollen, red, warm. Sometimes it's hard to tell if a Charcot or a bad infection.
So it's this incredibly complex mix. Nerve damage, bad circulation, altered foot mechanics, all driven by high blood sugar. How do doctors figure out who's at risk or what's actually going on when someone presents with a problem?
Well, the source points to several key risk factors you need to look out for. Smoking is a big one.
Smoking, okay.
High blood sugar, obviously, high cholesterol, age, how long you've had diabetes, high insulin levels. Even certain medications can play a role.
And the injuries themselves, given the lack of pain, how do they usually start?
The source breaks it down into a few types. You can have a direct mechanical injury, Cut yourself, step on a nail, something that breaks the skin.
Right.
Then there are ischemic ulcers. They happen slowly from prolonged low pressure, maybe from a tight spot in a shoe, just constantly rubbing the side of your foot over time.
Okay.
But the most frequent cause, especially in a foot that can't feel properly, is repetitive stress.
Repetitive stress, just from walking around.
Exactly that. It's the constant, maybe moderate pressure under your foot with every single step.
Which a normal foot would notice.
Right, you'd feel discomfort, you'd shift your weight, you'd take the shoe off, but with neuropathy, you don't feel it. So the pressure just continues day after day. It can cause a blister deep down, which then breaks open into an ulcer, and that cycle just repeats, often without the person even realizing how bad it's getting.
Man, that really drives home the danger of not feeling pain. It's protective for a reason.
It absolutely is. And your source hammers this point. Infection is present in the majority of these ulcers, and it's a major driver of amputations.
Because you keep walking on it.
Yeah. Because the foot is numb, the person keeps walking on the injured, infected tissue. This can spread the infection deep into the foot, into the bone that's osteomyelitis, or through the soft tissues, necrotizing fasciitis, which is terrifyingly fast, or it leads to gangrene.
So assessing the foot thoroughly is just absolutely vital. What should a clinician be looking for?
The assessment has to start with a really detailed history. And remember, the main complaint might not be pain. It might be like CC in the case study, an odor or swelling.
So you have to ask the right questions.
You really do. Get the story of the wound. How long has it been there? How did it start? Any previous treatment. Ask specifically about pain or the lack of it. Because, and this is critical, any new pain in a foot that was previously numb is a huge red flag. Usually means infection or acute Charcot.
Okay. What else in the history?
Ask about vascular symptoms, leg cramps when walking, that's claudication, pain when resting that gets better if they dangle their leg over the side of the bed, pain at night that makes them get up and stand.
Those all point to circulation issues.
Right. Ask about neuropathy symptoms, numbness, tingling, burning, pins and needles, balance problems. And of course, get the full diabetes picture, how long they've had it, how it's controlled, A1C levels, other complications, medications.
Got it. Then the physical exam, what are the objective clues?
Well, beyond the basics like vital signs and lab tests looking for infection like a high white blood cell count or poor control, high blood sugar, high HbA1c, the exam of the foot itself is key.
What do you look for?
You inspect the wound carefully, size, depth, what kind of drainage is coming out, how much, any smell, any signs of gas bubbles under the skin. That's crepitus, a sign of gas gangrene and emergency. Is the skin around it red, swollen, warm? That's cellulitis.
What about the rest of the foot?
Look at the overall skin color. Does it get pale when you lift the leg up? Does the color take a long time to come back when you lower it? Does it get really red or purplish when it's hanging down dependent rubor? Those are all signs of poor circulation. Look for hair loss on the toes and foot, another sign. Look for those foot shape changes we talked about, hammer toes, bunions. Check hygiene, the condition of the nails.
And then actually touching the foot, palpation.
Yes, palpation. Feel for pulses. Behind the knee, popliteal, behind the inner ankle bone, posterior tibial, and on the top of the foot, dorsalis pedis. A key point from your source, though, arteries and diabetics can get really stiff and calcified.
So the pulse might feel strong even if the flow isn't great?
Exactly. Or it might make ABI measurements unreliable. So pulse checks are important, but you need other info too. Feel the skin temperature. Compare different areas. Any spot that feels significantly warmer than the rest. That could be inflammation, infection, or acute Charcot, even if it doesn't look red yet. Check for swelling, edema, and feel again for that crepitus, that crackling sensation under the skin.
And testing the nerves, how's that done?
This is absolutely non-negotiable for assessment.
Yeah.
The single most important test mentioned is the Simmons-Weinstein monofilament, usually the 5.071.
Okay, what is that?
It's basically a specific nylon filament. It's designed to bend when you apply exactly 10 grams of pressure. You touch it to specific points on the bottom of the foot.
And if the person can't feel it?
If they can't feel that 10 grams of pressure, it means they've lost protective sensation. They are at significantly higher risk of developing an ulcer because they won't feel those minor injuries or pressures.
That seems like a really crucial screening tool.
It is. The source stresses that every single person with diabetes needs a comprehensive foot exam at least once a year. And that includes this monofilament test. It identifies risk early. Other simple tests include checking vibration sense with a tuning fork, maybe pinprick sensation, and checking ankle reflexes, which often disappear with neuropathy.
So losing that 10-gram sensation is like a major alarm bell.
Absolutely critical takeaway. Definitely.
Beyond the physical exam, what other tools are used?
Well, standard lab work helps. Checking kidney function, creatinine, microalbumin, nutritional status, albumin levels, lipid profile, complete blood count, sedimentation rate. Those can be markers for infection.
And imaging.
Imaging usually starts with basic x-rays. They can show gas, foreign objects you might have stepped on, fractures, signs of bone infection, or Charcot changes. Although early osteomyelitis and early Charcot can look really similar on x-ray.
So x-rays aren't always definitive.
Not always, especially early on. That's when you might need a bone scan, or, often better, an MRI to help tell the difference between bone infection and Charcot changes.
Okay. And what about specifically checking the blood flow? You mentioned the pulses can be tricky.
Right, so vascular studies are essential. The ankle brachial index, or ABI, compares the blood pressure in your ankle to the pressure in your arm.
And what do the numbers mean?
A normal ABI is around 1.0. Below 0.9 suggests some PVD. An ABI below 0.5. That indicates pretty severe ischemia. Usually you need some kind of intervention like surgery to get enough blood flow to heal a wound if the ABI is that low.
But you said ABIs can be falsely high in diabetics?
They can, because of those stiff, calcified arteries that don't compress properly. So toe pressures become really important.
Measuring pressure right at the toe level.
Exactly. It bypasses those bigger calcified arteries. Generally, a toe pressure over, say, 50 or 60 millimeters of mercury, or a toe brachial index, TBI, over 0.7, is considered pretty good for healing potential. Doppler waveforms can also give more detail about the blood flow patterns. Is it smooth or turbulent and weak?
And if you suspect a blockage that needs fixing,
Then you might move to arteriography. That's where they inject dye and take x-rays to map out the arteries and pinpoint exactly where blockages are, usually done right before surgery. There are risks, like kidney damage from the dye, but less invasive options like magnetic resonance angiography, MRA, are also used sometimes.
wow, it sounds like a really complex puzzle to put together for each patient. Lots of different pieces of information.
It really is. Your source mentions classification systems like the Meggitt-Wagner scale or the University of Texas system that try to grade how severe a wound is based on depth, whether there's infection, and the vascular status. Help standardize things.
And the ADA, the American Diabetes Association, has guidelines too.
Yeah, consensus recommendations on evaluation. Looking at things like, how long has the wound been there? Is it getting worse? What treatments have already been tried? Pretty much the kind of info needed in that CC case study.
Does age play a big role in who gets these problems?
The source notes risk does vary. Young people with type 1 diabetes can definitely develop issues if their control is poor over many years. But overall risk is often lower than in older adults. Gestational diabetes during pregnancy, the risk is minimal for these kinds of foot problems.
So it's mostly older adults.
Yeah, the highest risk group is typically the elderly, mainly just due to the longer time they've had diabetes, allowing damage to accumulate. Plus, they often have more associated health problems, like widespread atherosclerosis.
Okay, so we've got a pretty good handle on the why and the how to assess. Now let's shift to taking action. How are these problems actually managed?
Right, management. It's definitely multi-pronged. Starting with the medical strategies, your source identifies offloading as arguably the single most crucial step.
Offloading. Just getting pressure off the wound or the risky area.
Exactly. If you have an ulcer or even just a spot with really high pressure that's likely to break down, you have to reduce or eliminate the weight and pressure on it. Otherwise, it just can't heal.
How do you do that?
There are lots of ways. Custom orthotics, inserts that redistribute pressure, special diabetic shoes, often with extra depth, commercial boots like walking boots, sometimes wedge shoes that take pressure off the front or back of the foot, crutches, maybe a wheelchair. In really severe cases, strict bed rest might be needed, but getting people completely off their feet long-term is often really challenging.
Makes sense. What about infection control?
Absolutely vital. The source really stresses that you should start antibiotics based on clinical signs of infection. Meaning things like increasing swelling, redness spreading, pus draining, maybe a fever, or even just unexplained high blood sugar levels. Don't necessarily wait for culture results if it looks infected.
And that point about pain.
Yes. Remember, pain in a previously numb foot is a serious warning sign, usually pointing to infection or maybe acute Charcot. Get those deep tissue cultures if you can. They're much better than surface swabs for figuring out the right antibiotic. And always suspect bone infection if you have a deep ulcer that just won't heal, or if you can probe down and feel bone at the base. Severe signs like crepitus or a fluctuant pocket need immediate aggressive treatment.
Okay. What about the wound itself? Cleaning it out?
Yeah, wound debridement. Removing dead, devitalized tissue is necessary so healthy tissue can grow. The source mentions a few ways. Enzymatic debridement uses special ointments or solutions to break down the dead stuff.
Uh-huh.
Autolytic debridement uses moisture-retentive dressings, things like hydrocolloids or hydrogels. They keep the wound moist, allowing the body's own enzymes to dissolve the dead tissue. It's slower, but painless and inexpensive. Big caveat, though. You don't use autolytic debridement if there's active infection.
Right. Infection needs more aggressive cleaning.
Definitely. Sharp surgical debridement, actually cutting away the dead tissue, might be needed, especially if there's thick, hard, dry eschar covering the wound. Another option mentioned for offloading is the total contact cast.
A cast.
Yeah, especially molded cast that fits the leg and foot perfectly. It provides excellent pressure distribution, really good offloading. The downside is you can't easily see or access the wound underneath for daily checks or care.
Seems like a trade-off. And sometimes medical management isn't enough and surgery is required.
Yes, sometimes surgery is necessary. And your source lays out the main goals. Drain any infection, remove dead or infected tissue and bone, correct deformities that are causing pressure points, reduce the risk of future ulcers or amputations, restore stability and function, and importantly, prevent a major limb amputation. Saving the leg is the ultimate goal.
What kinds of surgery are we talking about here?
Well, the source breaks it down. There can be elective surgeries, maybe fixing a bunion or hammer toe in someone with diabetes who still has decent sensation and circulation to prevent future problems.
Yeah.
Then there's prophylactic surgery. This is done on a foot that's identified as high risk, specifically to prevent ulcers or breakdown. Things like correcting a Charcot deformity, straightening severe hammer toes, or maybe lengthening a tight Achilles tendon to improve foot mechanics and reduce forefoot pressure.
And then
The urgent stuff.
there's emergent surgery. This is for severe, limb-threatening, or even life-threatening situations. Bad infections, rapidly spreading gangrene. Requires immediate action, maybe incision and drainage to let pus out, extensive debridement of dead tissue, sometimes emergency revascularization to restore blood flow, or unfortunately an urgent amputation.
You mentioned revascularization, improving blood flow surgically. When is that done?
Exactly. Bypass surgery or sometimes angioplasty stenting. It's indicated when there's actual tissue necrosis, tissue death, combined with documented poor circulation, and the goal is to save the limb. Or sometimes for severe rest pain that can't be controlled otherwise.
It doesn't always work. Success really depends on having adequate outflow vessels down in the foot for the bypass graft to connect to. Ideally, the source mentions, you want good flow restored down to that dorsalis teres artery on top of the foot. And a really key point they make, active infection must be controlled first. You don't want to do major vascular surgery through an infected area if you can avoid it.
Makes sense. Are the results good for these bypasses in diabetics?
Actually, yeah. Your source mentions studies, like the Hyperbaric study, showing surprisingly high success rates for graft patency keeping the bypass open and for limb salvage, even in complex diabetic cases. But of course, there are risks. Infection, the graft failing, needing more surgery, potential limb loss anyway, or even death from other underlying health problems.
And what about gangrene? How is that managed if tissue has already died?
Depends if it's wet or dry. Wet gangrene is usually acute, often infected, foul-smelling. It's a surgical emergency, needs prompt removal of the dead tissue, IV antibiotics, and you have to watch closely for gas gangrene.
And dry gangrene?
Dry gangrene is usually slower, more chronic. The tissue is dead, black, shriveled, but not acutely infected. The main goal is to keep it dry, prevent it from getting infected. Sometimes revascularization might be attempted first to improve blood flow to the healthy tissue nearby before any debridement or amputation. In some cases, if it's very localized, dry, and stable, it might even painlessly separate on its own over time. That's autoamputation.
And unfortunately, amputation is sometimes the only remaining option.
Yes, sadly. It can be non-emergent, maybe for recurrent wounds that just won't heal despite every effort in someone who's otherwise relatively stable. Or it can be emergent for those situations like overwhelming infection, widespread gangrene, severe trauma, or PVD that just can't be fixed.
How do they decide where to amputate?
The level of amputation is crucial. It has to be high enough to remove all the dead or infected tissue, but low enough to preserve as much function as possible. The key is finding a level where the remaining tissue is healthy and has good enough blood supply to heal the surgical wound.
Are there markers for good healing potential?
Yeah, your source lists several. Things like adequate TCPO2, that's transcutaneous oxygen measurement on the skin, good toe pressures, acceptable AVI values. Also important are good nutritional status albumin levels and having the diabetes and any infection well controlled before elective amputation surgery. They list different types, from just amputating a toe, digital to removing a toe and its metatarsal bone, re-amputation, cutting across the foot bones, transmetatarsal, or more complex procedures for Charcot feet.
Beyond the big interventions like surgery, what are the basic principles of just everyday wound care?
Right, the day-to-day stuff. Your source reinforces starting with that assessment again. Is there infection? How much drainage? Size? Depth? What does the base of the wound look like? Healthy red tissue, yellow slough, black eschar. How's the skin around the wound? What's the overall status of the limb?
Got it. Assess first.
Then the goals are tailored.
Mhm.
Managing odor often comes down to managing bacteria and controlling heavy drainage.
And picking the right dressing. Seems like there are tons of options.
There are. And the choice really depends on the wound characteristics. Is the wound bed dry? Maybe it needs a hydrogel to add moisture. Mild to moderate drainage. A hydrocolloid might work well. Heavy drainage. You need something more absorbent, like an alginate or a foam dressing. If there's yellowish, stringy, slow, maybe those autolytic dressings or an enzymatic debrider. Hard black eschar usually needs sharp debridement first.
Okay. What about protecting the wound and just the foot in general during healing?
This is absolutely vital. Pain management is part of it. Moisture-retentive dressings themselves can soothe nerve endings. Pre-medicating before dressing changes if the foot is painful. Although, paradoxically, many with ulcers have no pain because of the neuropathy. Protect the healthy skin around the wound from getting waterlogged by drainage or damaged by tape.
And offloading again?
Always offloading. You can't heal if you're still putting pressure on it. Keep the extremity warm. Just simple things like wearing socks. But never use heating pads or hot water bottles on numb feet. You can cause a severe burn without realizing it.
That's a really important warning.
Huge difference maker. Proper footwear is crucial even after healing. Extra depth, extra width shoes. Using prescribed orthotics consistently to keep pressure distributed evenly. And your source has some really practical, simple tips here.
Like what?
Like always inspect the inside of your shoes before you put them on. Every single time. Feel around with your hand. Is there a pebble? A rough seam? Is the lining wrinkled up? Things you wouldn't feel with your foot if you have neuropathy.
Simple, but potentially limb-saving.
Totally. And the absolute cardinal rules stressed over and over. Never go barefoot, not even in the house. Always wear some kind of protective footwear, even slippers, as long as they fit well and have a protective sole. Practice good hygiene when changing dressings. Wash your hands thoroughly. Use tape on the dressing, not directly on fragile skin.
And smoking.
Avoid smoking. It drastically reduces circulation and cripples the healing process.
And the absolute most important instruction from this whole chapter, the one thing you really want the listener to take away.
If I had to pick one, it's report ANY sign of a foot problem or injury immediately. Don't wait. No matter how small it seems, a cut, a blister, a sore spot, new swelling, redness, warmth, any drainage, any odor, don't think, oh, it doesn't hurt, it's probably fine. Waiting, like in that CC case study, because you don't feel pain, allows minor problems to escalate incredibly quickly into limb-threatening emergencies. Early detection and treatment are everything.
So, wrapping this deep dive up then, what this source material really drives home is that diabetic foot problems are, yes, severe complications. They're driven by really complex damage from high blood sugar primarily hitting the nerves and the blood vessels.
Wow.
Assessing these problems requires looking beyond just obvious symptoms, using specific exams like that monofilament test, and often advanced imaging and vascular studies.
Right, and management is intensive. It involves those crucial steps like offloading pressure, aggressively controlling infection, meticulous wound care, and sometimes pretty significant surgical interventions.
Yeah, but the chapter isn't just doom and gloom about the complexity and the risks, is it?
Not at all. It also powerfully highlights the incredible impact of knowledge and prevention. Patient education is key.
And this really brings us to that provocative final thought the source leaves us with, something for you, the listener, to really chew on. It states quite clearly that while these complications are severe, a leading cause of amputation, patient education, and consistent proper foot care by themselves can reduce the amputation rate by as much as 80%.
80%.
Yeah.
Just think about that. What does that single statistic, pulls from studies mentioned right in your source, tell us about the profound potential you have? Through knowledge, through vigilance, through those simple daily checks, you have the power to dramatically change the trajectory of this potentially devastating complication.
80%, that's huge, something really significant to think about. We've taken a deep dive into this critical material today, really aiming to pull out the most vital insights just for you.